This presentation is directed to throw a light on some of our common practice in wrong direction while we are treating a hemodynamic unstable baby. So do your best, don't harm. I will speak about only 3 points of concern. Number one is the approach for a sick neonate with hemodynamic instability based only on the map or mainly on the map. Number two, the use of dopamine by default as the initial drug with increasing dose from 5 to 10 to 15 to 20 and sometimes introducing dopamine in between. Number three is approach without considering the pathophysiology of the disease itself and the change in the pathophysiology itself from time to time. So, the hemodynamic instability in neonate, especially the extreme low birth weight or sick baby, are common and it has different underlying pathology, especially during the transitional period. It is very important to be management in a good way because of the high risk of dysregulated systemic and cerebral blood flow, which may affect the survival rate and the outcome and give us a bad neurodevelopmental outcome. So during the transition period, especially the first 24 hours after clamping of the cord, removal of the placental circulation, the baby will have low systemic blood flow with compensatory vasoconstriction at first, which usually after day one start to be corrected and the systemic blood flow will return to normal or maybe come high because of some vasodilatation effect, plus or minus hypotension, but still we don't know what is the meaning of hypotension in a baby and what is the level at which you can say hypotension. So the most important is the systemic blood flow. The blood flow is important than the number of the blood pressure. So if we have an echo to be used to guide us in treatment of a sick baby with hemodynamic instability would be better, but if we will use empirical medication in the first 24 hours, especially in the first 24 hours, so any trope that reduce after load, like dopamine for example, will be with good benefit. Later on, we can use vasoconstrictor drug like dopamine if there will be association with hypotension plus the hemodynamic instability with systemic blood flow affected. So the point one, which is the mean blood pressure, we have to tell you that the hypotension is not a disease. It is just a marker reflecting the compromised systemic blood flow, and the hypotension can occur with any pathophysiology change or any disease. There is a lot of pathophysiology which can affect and a lot of contributing factor which can affect the systemic blood flow, and systemic blood flow might be compromised with normal blood pressure, low blood pressure, or even high blood pressure. So, fact number one, not all hypotensive infants need treatment if the systemic blood flow is adequate. Number two, the approach mainly based on the map is not accurate and it is represent only a simple inaccurate underestimation. So the main concern will be the systemic blood flow, and there is a lot of factors, as we said, which interact with the systemic blood flow to control, and the interrelation like blood pressure, and its factors which is affected by and in relation with the blood pressure, the vascular resistance, and the cardiac output. There is other factor which affect the systemic blood flow directly or through affecting of the blood pressure, like the regulator of the vascular tone, like the pH and PCO2, the pathology itself and the mediator which release from the body due to this pathology, like in cases of sepsis or other disease, and some factor related to the cardiac output itself, like the heart rate in some cases of tachyarrhythmia, the stroke volume change, and the interrelation with the preload and afterload, and the relation also with the myocardial contractility of the baby. These all factors interact together to maintain the systemic blood flow as normal. So in sick baby, if you want to give medication like inotropic medication, you have to know that this treatment can affect the baby, can affect the systemic blood flow by acting in different way and different mechanism. And don't forget that also it can affect the pulmonary vasculature and the pulmonary flow and also the cerebral blood flow. So we have to know the way of action of our medication, and you have to know also the pathology or the underlying factor which affects the systemic blood flow to start the treatment from this point. So the 6 drugs which we are usually using in the NICU are dopamine, norepinephrine, dobutamine, milrinone, epinephrine, vasopressin. So if you go to the main inotropes, which is the dobutamine, it is potent inotropic, but has no effect or minimal effect in the systemic vascular resistance, so seldom it causes hypotension, but no effect on the pulmonary vascular resistance. If you go to the second one is the milrinone, and it has beneficial effect that it decreases the pulmonary vascular resistance, so it is helpful in cases where there is dysfunction of the myocardium or the baby has hemodynamic instability plus pulmonary hypertension. But we have to take care that it causes also hypotension by its effect on the systemic vascular resistance. If you go to dopamine, it is mainly a vasopressor, especially after the dose of 10, when you are increasing dose to 10. But as you see here, it's the effect on the pulmonary vascular resistance is more than the systemic, so it is not good choice if you have pulmonary hypertension association. The inotropic effect is minimal up to 10. After 10, it is mainly vasopressor. If you compare with the adrenaline, the effect here, it is more vasopressor on the systemic rather than the pulmonary. So it's benefit if you have pulmonary hypertension, and it has powerful inotropic effects. This is the king of this group of medication. Norepinephrine has another benefit that it reduces the pulmonary vascular resistance, plus its inotropic effect and potent vasoconstrictor for the systemic circulation. And vasopressin has the same effect, but it has no inotropic effect. So to summarize, the predominant vasopressor if you want to use a vasopressor drug is a norepinephrine, vasopressin, and dopamine, while if you want to use a predominant inotropic drug, it will be dobutamine and milrinone. And epinephrine is a potent non-selective vasoconstrictive, and at the same time is a potent inotropic drug. So the second point of concern is the use of dopamine as a drug of choice to start with in every case. This is wrong. And why? Because there is a pathophysiology which must be considered in our thinking before using the drug, which point of concern which we need to start the treatment. Number one. Number two, we have to know that there is a limitation of dopamine, especially in preterm and in neonates. The clearance rates decrease in preterm and neonates has more vasoconstrictive effects in the pulmonary circulation more than the systemic vessel, and so its effect will not be of beneficial in case of dysfunction of the myocardium or hemodynamic unstable baby association with the pulmonary hypertension, and also in in some cases has variable unpredicted effects related to its inotropic and vasoconstrictive effect, like in low dose in state of causing diuresis by the vasodilator effect on the vasculature of the renal. It causes abnormal high stimulation of the alpha receptor and cause more vasoconstriction, and it cause reduce the urine output. Plus also in low dose it will act also in the dopamine 1 receptor present in the cerebral and the coronary, and may affect the cerebral circulation. And in case of using of 5 to 10, because it is dose dependent, it will stimulate the alpha adrenergic receptor and cause just mild vasopressor effect, while the inotropic effect is still not so potent. But if you increase more than 10, become pure vasopressive drug, more vasoconstriction. So it is not the optimal in the first 24 hours where there is compensatory vasoconstriction, or when the afterload is not of benefit to be increased against a failing myocardium. This point, especially I am giving a point for cases of pulmonary hypertension when there is association with myocardial dysfunction in sick baby or hemodynamic unstable baby, where the hypoxia cause more increase in the pulmonary vasculature vasoconstriction rather than the systemic vessel, and they increase the ratio between the pressure, pulmonary pressure and the systemic pressure. So preferred drug here will be the drug which has relatively less vasoconstrictive effect on the pulmonary vasculature. And if there is myocardial dysfunction and you want to use inotrope, so dopamine with good benefit and milrinone with a good benefit, and they also decrease the pulmonary hypertension, but be careful that it may cause systemic blood pressure low. So after we discuss now the 3 points of concern of number one, if we are not considering the pathophysiology and the etiology in our consideration. Number two, our use of MAP as the main predictor for a baby with hemodynamic instability. And number three, which is related to use of dopamine as initial drug by default with increasing dose till 20. Now, how to improve the quality of care and the outcome. Number one, we have to understand the physiology of the hemodynamic of a normal baby and the pathophysiology of the disease. We have to know the properties of the vasoactive and the inotropic medication which we are using. We have to know that there is a limitation of using the MAP alone, and you have to use the systolic and the diastolic blood pressure in our consideration, because they will reflect a lot of factors like the contractility, give us some information about the preloads, afterloads, the stroke volume. Point three, that use echocardiogram if possible, it will be helpful. And four, try to identify shock as early as possible. This is like algorithm. If you have a baby, hemodynamic unstable, systemic blood flow may be normal or low, the blood pressure may be normal or low. So If the systemic blood flow and the hemodynamic of the baby is okay and blood pressure is okay, so no treatment. This is out of our consideration. Number 2, if the systemic blood flow is okay, but the blood pressure is low, in this situation, you have to wait to observe and evaluate. Don't rush to give treatment and then decide later on. But number 3 and 4 are very important. If you have the systemic blood flow affected, hemodynamic significantly affected the baby, and the blood pressure is normal, so here we can use dopamine. We don't need to use a vasoconstrictor, except if after dopamine you have feeling of the blood pressure at that time, or the effect on the myocardium is still not good, you have to use low dose of adrenaline. But if from the start the blood pressure was low and still we didn't do echo, so also start dopamine for the myocardium for the inotropic effect, then you can add the vasopressor later on. Thank you very much, Andy. For more detail and if you want to see the approach to different scenario with different pathology, please visit this site and do your best. Don't harm. Thank you very much.